My name is Dr. Shokat Memon, and I'm working as a consultant nephrologist in the Indus Hospital and Health Network. So today we are going to discuss about the very commonly seen topic and very important, especially for the resident who are working in the medicine department, in nephrology department, or trainee medical officer. All of them will really find this useful. I've tried my best to make it as simple as possible. So anion gap जो हम देखते रहते हैं कॉमनली आईसीयू सेटिंग में, इमरजेंसी सेटिंग में, वार्ड सेटिंग में, तो नॉर्मली क्या होता है कि जो बॉडी है वो एक न्यूट्रलिटी पे बेस करती है, यानी जितने कैटाइंस हैं पॉजिटिवली चार्ज उतने ही एनाइंस हैं नेगेटिवली चार्ज। ये एग्जांपल्स हैं जो सोडियम, पोटेशियम, कैल्शियम, मैग्नीशियम, ग्लोबुलिन, ये पॉजिटिवली चार्ज हैं और ये जो नेगेटिवली चार्ज हैं क्लोराइड, बाइकार्बोनेट, एल्ब्यूमिन, सल्फेट, फास्फेट। तो ये एक बैलेंस होता है, लेकिन फॉर द सेक ऑफ डायग्नोजिंग understanding the disease better, this artificially created anion gap, which is met with inclusion of the sodium minus chloride and bicarbonate. The the resulting figure digit is known as anion gap, which typically taken as 8 to 12, and uh, this helps in diagnosing many of the disease where this gap uh, becomes more due to the accumulation of anions. So we will understand it in bit more detail if you look at this slide. I have shown the predominantly cation present in the body is sodium, and when we minus sodium minus bicarbonate and chloride, we get the anion gap. So sodium is a primary cation, and the primary anions chloride and bicarbonate, and we get the anion gap. In other words, you can see over here the unmeasured cations, which are not included in this calculation process, but they are present. The cations and anions which are unmeasured, they are not unmeasurable but unmeasured. So what happens if we want to take these unmeasured cation and anions, and if want to know about the anion gap, then this should be minus from that one. We will get the anion gap again. I will show it in other slide. So here the same thing, primary cation, primary anions, and we got the anion gap. Now what happens when we minus all unmeasured cations, which are these, from the unmeasured anion, which are these, and we get the serum anion gap. The same way to look at the same things which we have seen when we did when we took sodium and we minus chloride and bicarbonate, we got anion gap. So the same thing, again emphasizing, making it more understandable. The primary anion minus primary uh, primary cation minus primary anion is the anion gap, and unmeasured anion minus unmeasured cations, again the anion gap is typically taken as a 8 to 12. Let me share one study done 2017 where the review of the diagnostic evolution of the normal anion gap metabolic acidosis seen, and almost 4,525 healthy adults were included in that study, and anion gap was seen among them. So it came as the range from 8.5 to 15.2. So they were all the healthy population. So you can see the lowest 8.5, again that could be the normal, and the highest normal is 15.2, but typically the mean value was taken as 11.6. So for the sake of more understanding clarity, we usually take it 8 to 12, and the middle figure is the 10. Now what happens, this we have discussed, okay, unmeasured anions, unmeasured cations. Uh, so so the increase in anion gap is either due to unmeasured anion, which is this one, due to any reason this portion is increased, then again this would be reflected into the increase in anion gap. Or if this portion is decreased, this is decreased unmeasured cation, again this will give rise to the increase in anion gap. Now we will look at many of the diseases which are commonly seen. So one by one, the much more commonly seen is renal failure, where we see the anions get accumulated, and usually those anions suppress phosphate, and that give rise to the elevation of anion gap. And here we have arbitrarily taken as a 20, and the serum bicarbonate is 14. What happen if we calculate delta anion gap, means change in anion gap? If we take the 10 as typically cutoff figure, then the digit 10 is raised from that typically 10, the normal stand. And change in bicarb, again, if the serum bicarb of that particular patient, these are arbitrarily given the values, supposing a patient who has these serum levels. So now it will make more understanding. So here the change in bicarb, the cutoff value is taken as 24. The change in bicarb is 10. So ratio become 1 is to 1. So that is a typically high anion gap metabolic acidosis. And you look at another commonly seen disease, the diabetic ketoacidosis, where we know the accumulated anions are the ketones, ketoacids, hydroxyc acids, and that accumulated at the cost of declining of bicarbonate. Again, we have taken the same figure 14. So the increase in anion gap due to these accumulation is raised from 20. So the change is 10. Both of these condition, as we see in previous example, the ratios becomes 1 is to 1. The same high anion gap metabolic acidosis, and so is the case with lactic acidosis. For the sake of understanding, I have put the same values, and here the accumulated ion are the lactate, and high anion gap metabolic acidosis. In case of alcoholic poisoning, anions are the format and oxalate. These are organic acids, and the same disease severity I have put, and high anion gap metabolic acidosis is found. And drug poisoning, again the same, putting the same values, we just have the high anion gap metabolic acidosis. Now last two example you will see the diarrhea and renal tubular acidosis. Here I have put the value of 14, which is the same, but the anion gap is not raised. And here the raised anion is the chloride, which is also called hyperchloremic metabolic acidosis, where the anion gap comes as a normal. There's no change in the anion gap. So we call it a normal anion gap metabolic acidosis. And in case of renal tubular acidosis, again, putting the same value of bicarbonate, there's no raised anion gap because of metabolic acidosis occurring at the cost of chlorides. So this is the normal anion gap metabolic acidosis. So these are the commonly seen conditions, but you may encounter the different values over here in whenever you are seeing the actual patients. But for the sake of understanding, you have just make it simpler so that the concept is understandable. So I've already discussed these two conditions of this change where we have found no increase in anion gap. Now let's talk about the condition where we find the increase in anion gap other than what we have mentioned. A small elevation of anion gap, which is not commonly seen, may be found if the albumin, baseline albumin is increased, or phosphate is increased, or anionic paraprotein, which is immunoglobulin A, not other immunoglobulin. All these conditions give rise to some elevation of anion gap, and some elevation of anion gap also can be seen into metabolic alkalosis. Please be keep in your mind regarding that too. And you should know about the other thing too, where which is the corrected anion gap. What happens if we are dealing a patient who has a baseline of albumin less than 4, then we need to correct that anion gap. And the formula of correction of anion gap is typical cutoff value is 4 minus serum albumin of that patient, and we multiply it 2.4 plus calculated anion gap. Then we just get the true anion gap. So what happens, the normal value of 10 on 8 to 12 anion gap is based on the normal serum albumin, which is 4. But if you encounter a patient with a different serum albumin, then you need to adjust it, because the 8 to 12, the figure is taken at when they assuming the serum albumin is 4. So when the patient serum albumin 3, you have to minus 2.5 in order to get the normal anion gap, or other way around, you can just put the values into that to get the true anion gap. Hope this makes you understand. If you are unable to understand, you can write down in the comment box too. And these are the conditions where we find low anion gap. So if someone working the ward was intelligent enough and find the and habitual of calculating the anion gap, find the low anion gap, then he or she can find the reason would come one of these: hypoalbuminemia or hyperkalemia, hypercalcemia, hypermagnesemia, lithium toxicity, और जो multiple myeloma पेशेंट होते हैं immunoglobulin G जिनमें पड़ा होता है, तो they all give rise to reduction into the anion gap, and this way we can reach to the diagnosis. And in also let's talk about some, and sometime we find the negative anion gap, which is rarely seen, but it's most likely come as an error of the laboratory, which is of course not reproducible. When you recheck the sample, it comes normal, or this overestimation of serum chloride, marked hyperlipidemia, cell silent intoxication, yeah, bromide की intoxication होती है, तो all of them can give rise to negative anion gap. So thank you very much for this time. Hope this would be beneficial to you. And if you have a question, you have comment, then you please write down the comment box. Inshallah, we'll discuss. I will also share my email address. And thank you very much. Take care.